with a question on something that is part of hematology, is very novel. The series touch on it a little bit, some of the papers, and this is about gene therapy. So Gaston Mathandu asked for Julie, but I guess, Ambroise, you can also put your thoughts about this there, since your paper is about sickle cell disease. And he says, when I hear about gene therapy, I always think about its cost involved. So considering the cost, how can gene therapy be made readily available in Africa? The burden of disease in Africa can be used as an argument, perhaps, to say the cost will be shared among affected people, but still these people are generally poor and several African governments are not involved, do not care. So how to deal with the cost? Challenging question to start.
It's good for Juliet.
Absolutely. So we've been looking at that, Gaston, really, and just for people to know, Gaston is a fantastic statistician and bioinformatics, working in SADC with Ambrose and Emil Chimusa. So it's been fantastic working with Gaston. So one of the things that we've been doing, and the picture that I showed with Grace and I at the meeting with Elian Gluckman and others, is really trying to make sure that we address the issue of equity. Just as a context, bone marrow transplant in the US or in the UK cost is around, this is bone marrow transplant, this is around $100,000 to $150,000. If you do it in India, some of the centers in India, it's around $60,000. We have done the numbers and we are confident, and there already is transplant that's ongoing by Nozi Bazwai in Nigeria, and there's a recent editorial that Lucho has written, in that we believe that we could do transplants in Africa at a cost of between $30,000 to $50,000. So that's the first thing, and as mentioned by Ambrose and myself, is that transplant is essentially the platform for ex vivo gene therapy. So that's the first thing. The second thing is that governments are engaged. All the governments, if you go to Ghana, Nigeria, Tanzania, you will find extensive investment in tertiary level centers. You will see hospitals by the public sector, by the private sector, that have been invested and can do transplants and are able to do transplants. One of the critical stumbling blocks for transplantation is blood transfusion. And you've heard from Yvonne the fantastic work that they're doing. Blood transfusion has been one of the limiting factors in terms of being able to provide safe bone marrow transplantation. So that's something that we do. The context of comparison with gene therapy, when you think about gene therapy, I mentioned transplant is $100,000 per transplant. Gene therapy is around $1.2 million. Huge amount. So we've been working with an initiative called the Global Gene Therapy Initiative. This is an initiative that is open for anybody to be a part of, and we'd really welcome you to be a part of. It was founded by Dr. Sisi Kicho from the Joint Clinical Research Center in Uganda, and Jennifer Day from Fred Hutch in the US. And it has it's open. It's open to everyone. We meet every Thursday and we talk about issues around the whole thing about equity and access. So with Caring Crops, which is one of the NGOs that was started by Boro, we are hoping to have a manufacturing plant in Uganda and another one in India that will be able to manufacture the vectors, the product, so that when we get the stem cells from patients, rather than send the stem cells, and this is work that Mohammed Zahir is doing, looking at CD34, looking at how we can collect them either from cord blood or from peripheral blood, and then process them so that we can send them to a processing center as close to the patient as possible, so that they can manipulate, do the transaction, and then we get them the product back and transfuse it to the patient. So this is something that through Caring Cross GGTI, we're looking at the first center that seems to be ready and is working to be ready will be in Uganda. Once the most expensive thing, and this is where there's a lot of discussion, the most expensive thing is the vector when it comes to gene therapy. And if we're able to get around the vector and the cost of the vector, then it will be available. The final thing that I should mention, I think, in when we were in Ethiopia for the last H3 Africa meeting, the NIH and the World Cup, the NIH and the Gates Foundation announced an investment of 200 million US dollars to gene-based therapy for sickle cell disease and HIV in Africa. So that investment, the bulk of that investment has gone into centers outside of Africa. The interesting and the exciting thing about that investment is that they are looking, and we hope that in the next iteration of this, that African investigators will be involved. But what we're doing is that we're looking to see if we can do in vivo gene editing. This is something that would really mean that rather than go through the process of myeloablation that is required for ex vivo gene therapy, when you do in vivo gene therapy, you don't need to have that process. And so that is a technology. It's not there yet, but there's a lot of very, very exciting work that's ongoing. Final thing that I want to say to answer your question, Gaston, and expand on it a little bit, this is where I think we are, and the opportunity that H3 Africa, Tanzania Society of Human Genetics, and African Society of Human Genetics is very well positioned, is with regards to understanding the genetic factors that influence erythropoiesis and influence the immune system when it comes to handling both the vector and the immune reconstitution that comes on after transplantation, as well as after that. There's been safety concerns, before anybody asks, there's been safety concerns about gene therapy, and this is something that is being taken very, very seriously. Charmaine is here, and she may want to talk about that, taken very, very seriously, and this is why we're very lucky that we're working so closely with our patient community. The plan is that with the genomic capacity that we've developed, we'll be able to answer the questions about erythropoiesis, about immune reconstitution, about immune system in response to either the vector or the process itself. And so we're very excited that we will be part of the process. There's a lot of discussion, a lot of support, and the cost issue is something that our governments are very much engaged, and it's something that we'll be doing. Gaston, if we do not transplant patients in Africa, they will leave and get transplants there. And we've got experience from Uganda, fantastic work again that's been done by Dr. Francis, Dr. Siksi, and others, where they've shown with the cohorts of patients who've gone and received transplants outside of Ghana, what the survival outcome is. So there's a lot of lesson and a lot of capacity here. I'll stop there. I could talk forever, but thank you.
Yeah, thank you, Julie. Thank you so much for your elaborate answer. Next, perhaps we can focus on a question to Martin. Someone was asking anonymously whether gender is a risk factor for iron deficiency anemia, and what do we know about that?
Thanks, Isa. Thanks to the anonymous question. It's a really great question. Yes, I would say gender is a risk factor to iron deficiency anemia, and it's basically in the life cycle of our females, especially. We noted that when a child or a young lady becomes an adolescent, from that point on, when they start their menses, there is heavy bleeding, which in Africa, unfortunately, maybe because of various factors like culture and the like, we have not paid very close attention to that population group. And what you see is that that's the first point when they start becoming anemic because of the heavy bleeding. In the developed world, what you see is that there is access to contraceptives, for example, and to services where these young ladies can be guided into what to do, especially if they're having heavy bleeding, to counteract the iron loss. So that is also coupled with now the increased rates of early pregnancies in most countries. And therefore you find that by the time the young lady is hitting 15, 16, even sometimes about 18, majority of countries in sub-Saharan Africa are struggling with a lot of teenage pregnancies, a lot of young, the time of first pregnancy is very early in most of these countries. And then, as I explained in my presentation, that kickstarts a vicious cycle of going into pregnancy iron stores, and that keeps getting repeated and repeated over and over again. Now, the young men are not experiencing that. While the young ladies are going through this, the young men are not experiencing this. Instead, they are in a period of rapid growth, but largely because they don't lose the iron, not unless they, bleed or cut themselves, maybe rough spots or something. They don't have these same iron demands that women have during their monthly cycles, but also during the heavy demands of iron during the pregnancy period. That is the reason why I would conclude that, yes, there is a gender risk factor when you are talking about iron deficiency.
Okay, thank you for your answer, Martin. So thank you. So we are a little bit over time, but I would like to ask a question to each presenter if possible. So just run a little bit over. So the next one would be for Professor Wonkam. How prevalent is sickle cell disease in North Africa? And are sickle cell risk alleles selected for at mixed people with African ancestry?
Sickle cell is relatively common, but not as common as, for example, in Tanzania, Congo, or Nigeria. For example, in Nigeria, the frequency in the general population may be up to 25%, or in Congo. But in North Africa, we expect it to be around 10% in tribal area, but much lower, for example, in urban area.
Thank you.
Is there a mixed population selects for them? The answer is that we do not have any evidence for that. What we could say is that sickle cell disease is present in the southern part of Italy, is present in Greece. Actually, the first community screening for sickle cell started in Greece some years ago. The question that is from evolutionary perspective and migration perspective is, when does sickle cell disease arrive in southern part of Europe? So that might be very interesting. What we do know is that in that part of Europe, for example, the most common haplotype is the benign haplotype. We tend to suggest that the migration and a mixture with European in that part of Europe is very recent. When I say relatively recent, probably 5,000 years ago, but it's something that we still need to investigate.
Thank you. Thank you so much. And lastly, I would like to ask Yvonne, Judith Kumutini is asking, how much blood are we talking about to fill the gaps that are seen in the region? And is importing blood from elsewhere an option?
Well, thank you very much for that question. If I got it right, how much blood are we talking about? Well, WHO advocates for 100% voluntary blood donations. And so that is what we are aiming for. We are hoping that strategies some are being done by the Blood Safe Project, which is being sponsored by NHLBI. And this is supposed to find strategies to improve blood donation in the sub-region. So 3 countries are involved, and they are coming up with very innovative strategies, including using communication strategies like WhatsApp messaging, docudramas, iron supplementation, which has been done in other countries and not in Africa yet. So we are using interventions that we think will help with our blood donor pool. So definitely, yes, 100% voluntary blood donor pool. And maintaining them, retaining these donors. I think that is the most important thing. You can have 100%, but at the end of the day, if you don't retain a lot of them, you haven't really done much. So we need to have them and be able to retain them for use. Yeah. And the second question, was there a second?
Yeah, there was a follow-up to that, saying whether blood should be imported to fill those gaps.
think that if we're able to come up with all these interventions, and if these interventions help, definitely we would want to use our own. So getting blood from somewhere else, I don't think that should be considered as an option. Thank you.
Thank you. Yeah, and in your paper, you lay out how important it is to strengthen blood transfusion services. Yeah. Okay, so I think there are a few more questions still and some coming up in the chat, but we are 6 minutes over. So in the interest of time, I would like to finish the session now because the conference is still going and there are sessions later on that people have to join. So I would like to thank very much all presenters today for being here, also for your dedication to this project. And thank you so much also to all the viewers who joined us today. And with this, I would like to finish the session. Thank you so much, everyone.
Thank you very much.
Thank you.
Thank you very much. So thank you very much, guys, and thank you, everyone. So we'll just go back to Professor Christian Happy, who's chairing this this session, so that we can close we can have the break. Professor Happy, is he there?
Yes, I'm here. Very, very interesting presentation, very impressive presentations, generally, Julie and Ambrose and all of the presenters. I think you made us all proud, you know, because I remember a few years ago when we heard about this kind of talk and the science, we used to hear other people tell us about sickle cell in Africa. But today we are telling our stories ourselves, and then you are, and I can just be so proud. And you know, I was telling my little son a few days ago that I think, you know, when you grow up, go and do medicine and get inspired by Ambrose. Actually, he was looking at you. I was giving a talk and you showed up, and I said, look, that's your father, because I really got impressed. And Julie and every others, I think you really making us proud. And I can't stop saying this, because anytime I hear and I you, I know there is hope for this continent. You know, things are changing, and then I'm thanking all of you for taking the lead. We've gotten to a point now whereby, you know, I'm sure there is a lot of excitement out there, and at least I'm sure that a lot of the young people listening to you and listening to all this talk, and you could hear the questions coming from the public and from the audience, and you handle them so well. So I do think that, you know, at this moment, we are getting to a stage where when we look at the curriculum, I'm just making sure that I think we need to have, I just want to thank all of you. And then also, Yaisa, for moderating this session, you know, was really fantastic and so powerful. And with the synergy that we see now between the Lancet and then this group, I think that you're really going to be serving as a platform for advocacy, and then to have our voice heard and then louder than what Julia and Ambrose that are leading this team are providing out there. So I think really I want to thank everybody for this session, and I want to just create the indulgence of people. You know, we went a bit over, but we just want to, I mean, it was because of the excitement that we went over. And really, I want to thank everybody, and it was such a great session. So at this point, we will have to kind of close here.